Hi, everybody. I'm Woody. Well, as part of this ongoing series of interviewing just amazing people in diving, I thought it would be appropriate to interview, to me, number one, on day one of 2026, Dr. Doug Ebersole, who is with me. And Doug, I'm going to do something right now that you're going to hate.
Great.
That's not a great way to start an interview, right? You're going to hate it because what I'm going to do is something that is actually so amazing about you. I'm going to brag about you because you never, ever, ever do that about yourself. And you don't even like it. You're not comfortable with it. So I'm going to do it. So let me take 3 minutes, everybody, so you understand just the caliber of person here that I'm interviewing. So here we go. I'm going to have to read it because there's a lot of things, but it's worth hearing. Dr. Doug Ebersole with me today, not only one of my best friends, but was also my technical dive instructor from the beginning, is an interventional cardiologist at Watson Clinic in Lakeland, Florida. He's been there a long time. And he's a key cardiology. Originally, I printed it out. It said consultant for Divers Alert Network, but now the chairman of the board of Divers Alert Network, which we're going to get into. That's unbelievable. Congratulations on that. He's known for bringing his extensive medical experience, especially in structural heart issues and diving physiology like PFOs, with his deep passion for technical and, in particular, rebreather scuba diving. I think we'll get into that. I think it's he and I have many times talk about, honestly, we don't even want to dive anymore unless it's on a rebreather, but that's an interesting why that we'll talk about. He's often educating divers in the dive community through articles, webinars, presentations, and teaching. So listen to some of these key areas of expertise and focus. Doug, it's amazing. Interventional cardiology specializes in coronary and structural heart interventions. I think through doing a lot of procedures, not surgeries, procedures. By the way, I'm going to ask you what the difference is because I have no idea. Dive medicine, leading voice in cardiovascular health and divers, PFOs, decompression illness, immersion pulmonary edema, technical dive and experienced technical diver, cave instructor, trainer, particularly in rebreather diving, on not one rebreather, but I'm going to ask him on how many. As all I know is when I go into his garage, it's like a museum of rebreathers. Um, it goes on. He publishes articles in dive magazines. He hosts webinars for divers, improving safety and understanding of dive related medical conditions, and on and on. And, in essence, in summary, you're just such a respected cardiologist. And you also happen to be a highly experienced dive educator. So you really have become to so many, and it's really unanimous that anybody we talk to about you says that you're an invaluable resource, really at the intersection of heart health, but in underwater diving and education. So, of course, it was fitting for me to say, number one interview of 2026 is you. So, with that said, I'm going to start now asking questions and shutting up so we can hear from you because that's why everybody's here. I want to open this with one question, and I know I like to send my guests some questions ahead of time, but I didn't send you this one. Before we get into your amazing history, is there any one, you have to answer this, is there any one dive instructor that really stood out and influenced you and made you embark on this incredible diving journey after already being so successful as a cardiologist, and why is it this one person?
I'd have to go for that. I have to go way back. Because really what got me into diving was my first open water instructor. And I started diving back when you did. So that person was Jim Whitstruck, who was a longtime rep for Ziegel. I retired years ago, but he was my original diving instructor in 1974. And you remember these days, back in the day, this was a several month kind of journey. 2 nights a week, academics, pool. We did our checkout dives together, and then we became friends. And actually, I went on multiple trips with him. He kind of took me under his wing, and he was just a fun guy who was very safety conscious and a very good diver. And that's really what kind of basically sparked the passion because I think one of the main issues we have in dive training is we certify people, but we don't turn people into divers. And that's one of the problems with the industry. And back in the day, and you probably remember, it was more of a mentoring kind of thing. You got certified, but then you would go dive with the same person a lot, and you would kind of be mentored, and they would reach out to you and try to help you and so forth, and kind of turn people into actual divers that have lifelong commitments to the sport. And I think we can it'd be good for us to get back to that sort of thing. Some people do that, but a lot of times, as you know, it's a factory of how many people can you crank through on an open water class and so forth. So Jim is still a friend of mine. I still see him on Facebook. I used to always see him at DEMA shows. He's now retired, but so yeah, I'd have to give a shout out to him. I don't know if he'll watch this or not, but if so, I'll give him a shout out because he'd probably be that guy for me.
That's really cool. And you
And I'll give
do
you one
that.
other one too in a minute. But go
Oh,
ahead.
sure. Yeah, please.
Okay, the one other one would be Tom Mount. Because so Tom, for the people who don't know, founded the NACD. He was part of NSS CDS cave diving. He with Dick Rakowski took IAND nitrox divers into IANTD, International Association of Nitrox and Technical Divers. I met Tom in 2000 when he was I yeah, I forgot what his actual he may have been my azimuth instructor. But it was right when I got into technical diving and when I was starting with semi-closed rebreathers and stuff, and then he and I became lifelong friends. And he was a great friend and mentor for 25 years. Tom was a phenomenal diver, um, very passionate about dive safety and education, and I was fortunate enough to work with him and write quite a bit of the materials for INTD, some of their textbooks, wrote some of their courses, which we'll probably talk about later. So that'd be the two. Jim for my recreational diving and just sparking the passion, and then Tom for the technical diving side of things.
Well, you do that. You do mentor. And what I mean by that is if you look at and a lot of your students will probably listen to this, you end up being their friends and diving with them. And I know you mentor me as well. So it's not just take a class with you, get certified and thank you, good luck in your diving. It's really awesome that you do that. That is what we mean by mentoring. I think that's what you mean. And you just do it. You do it naturally. So
Yeah, I enjoy
um,
that. But we're here. We're here. Should be a fun activity, right?
I couldn't agree more. So we're going to get into more of that. Before we get into even a little bit more detail, another question I didn't send you, but I think it's important. It's going to lead into some of the conversation. What what if you can pick your favorite overall kind of diving, what is it and why? And what do you like to do on those dives?
Warm water and pretty fish. Okay. I mean, honestly, I do. We joke, and you know this. We joke that Carol, my wife, is an 80, 80, 80 diver. So the water has to be 80, the air has to be 80, and there needs to be 80 foot of visibility. And that's great if you can do that. And I love that, and that's my favorite kind of diving. Now, I am perfectly happy jumping in a dirty lake or a cave or a pond or cold water or warm or what I enjoy all of it. But as far as my favorite thing would be some sort of warm water, pretty fish, because I enjoy, as you know, I enjoy photography. So that, perfect style stuff for photography. And obviously, Carol, I'm sorry, Woody, but Carol is my favorite dive buddy. So dive with her in warm water, pretty fish around the world is always my highlight.
Do you think she's your favorite kind of diver because her face is different than mine? Would you say?
It's a
Look at
little, it's a little different. She has
a
a
better,
little more hair, a
a
little
little
bit more
better.
hair.
Okay,
Yeah, green eyes. Otherwise, you guys look similar. Yeah.
that's what I figured. The reason why I asked you that question is because as far as you've gotten instructor, trainer of many different agencies and so forth. It is interesting, and it's the same with me, that it's all the way back to the most basic beginning mellow dive. I agree. I just love jumping off of a boat on a warm, beautiful day in warm water and just looking at pretty fish and marine life in the ocean. And the spirit of that is that that's why we dive. In the end, it's really just about enjoying this activity. And it's just very interesting that that's still your favorite after all the different levels you've gotten into, which we're going to talk about now. And I really wanted to sort of say, just remember, why we dive, everybody. And Doug always portrays that with all the accolades he has. He loves this. That's why you do it.
And the
So,
other thing, and the other thing to be
yeah.
aware of is the camaraderie. Okay, I mean, a lot of people solo dive. I don't really solo dive. Maybe it's for photography, but if you go on a live aboard dive trip and do 5 dives a day, right? That's 5 hours. The other 19, okay, you're with other people. So the other thing about this activity is the camaraderie and sharing stories. And the reason you end up going to all these different places is you're on a boat talking to people and finding out where they've gone, what they've enjoyed, and it just becomes a really big community. So that's the other thing about this sport that's really enjoyable to me.
I have nothing to add. I absolutely agree. I love that. Well, let's talk about your military background. A lot of people may not know about that are watching this. So how did your experiences, I guess would be the right word, as a military cardiologist shape you really to approach both medicine and then somehow it rolls over into your diving? Like, are there specific lessons that you got in the military that you carry with you now, both in the way you practice medicine and the way you dive and the way you teach people to dive?
Okay, first, a little background. So the way I got into the military in the first place. So I learned to dive in 1974. So that was in early high school, like freshman year of high school. And that was because of Jacques Cousteau and all that kind of stuff was going on at the time. So that was always my interest. I got accepted to college at Duke. I had some academic scholarships, but not enough to cover all the cost. So I was saying, hey, I like the water. I've been in the water my entire life. I need a scholarship. I'll apply for a Navy ROTC scholarship because that's cool. I'll be in the around the water. So I was fortunate enough to be accepted for that. The problem was about a year into that, the Navy changed their policy. It used to be that you could finish your 4 years of Navy ROTC and then be deferred to go to medical school and then come back and be a Navy doctor. At that time, they changed it so that when you finish, you're going to have to go out and be a line officer for 4 years. And then you could come back and apply to medical school. And I kind of said that's not what I signed up for. So I was allowed to get out of my Navy scholarship after 2 years. Um, and interesting along this time, because you were alive around the same time, the Navy's motto at that time was join the Navy, see the world. Okay. The summer after my freshman year, I left out of Mayport, Florida, Jacksonville, basically. We left and I saw water for 60 days. Okay and came back. So yeah, join the Navy, see the world, 3/4 of it's water. Okay, that's what I saw. So, but anyway, so that led me to I worked, 3 jobs during the summers to try and make some money for spending money, and my parents scraped up enough to get me through the last 2 years at Duke, which I will always be grateful to them for. And then I applied for a military scholarship to go through medical school. Again, entirely financial. And this time chose the Army because I figured at least I could go home at the end of the day rather than still be on a boat. So my initial uh, military commitment was financial. Um, but that having been said, I'm quite patriotic. My dad was in the military and so forth, and so I thoroughly enjoyed all that. As far as military training, the military does some things extremely well. Um, they do ceremonies obviously very well, and the chain of command I think is excellent. So those kind of organizational things I think are very helpful for me now. I'm a firm believer in, chain of command and how all that works. Additionally, in the military, from a medical standpoint, not a lot of people stay in 20 years. A lot of people do their time and get out. So what that does is it allows you to progress very quickly because there's not a lot of people above you in your chain of command. So that by the time I got out of the military, so I had done my 4 years of medical school, which was a mixture of reserve status and active duty status in the summers, and then 10 years active after medical school. So I did my 3 years of medicine, 3 years of cardiology, and then stayed on for 4 years. By the end of the 4 years as staff cardiologist, I was running the fellowship program. I was in charge of the cath lab. I'd already been in charge of the coronary care unit. So you get lots of administrative experience, which is also quite helpful in managing people and managing budgets. So I thought that was very, very helpful from a business standpoint. The other thing that's very nice about my time in the military is you're allowed to practice pure medicine. There's no financial gains in the military. I was on a salary. So no matter what I did, I got paid the same. So I could be very pure, which I'd like to think I would do anyway, but I had no financial incentive to do this or not do this. It's take care of the patient, and you get your paycheck. Okay. So that has put into me, I don't think I believe this anyway, but has really stressed to me. And what I try to stress to all the young doctors coming out is I tell them, look, take care of the patient. The money will take care of itself. Just do the best thing for your patient. Don't worry about the money. The money will take care of itself. And I think the military kind of helped me with that as well, just because of the fact that you're on salary and it's just pure medicine.
When you then, what happened after the military then? What did you do? Did you have a plan? Did you
Okay.
just
Okay. Do we have a plan? Yeah. So yeah, basically. So from a diving standpoint, by the way, so I basically dove all through college. I dove through medical school a little bit. I got into windsurfing, but that's a whole different story. We can talk about that. But and that sidelined me for a while because I was on tour and so forth. Um, but anyway, so we were in Texas. My wife, Carol and I met in medical school. She was on a military scholarship as well. Initially Air Force. She switched to the Army when we got engaged, so we could have joint assignments. So we spent 10 years in San Antonio, Texas, not the diving mecca of the world, but a little bit of diving. We always knew we both wanted to come back from Florida to Florida. I grew up in St. Pete. She grew up in St. Augustine. So as we were getting close to getting out of the military with our commitment, we started looking back in Florida, and that's how we found the job here at Watson Clinic in Lakeland. And we came here in 1996, and we've been here ever since. When we got back to Florida, I got back into diving. She then got certified in 2000. Kim, who obviously our daughter got certified in 2001 when she was 12, and our son in 2003 when he was 10. And we've been a diving family kind of ever since. So we had a plan of how to get of our plan of getting out of the military after our commitment was due. So basically, I had 14 years for pay purposes when I got out.
you met Carol in the military?
I met Carol in medical school. Actually, we were both
Oh,
on scholarship.
wow.
Yeah, actually,
Okay.
the interesting story. She was a year behind me, and she'd been on part of her military training the summer before she started medical school, and met someone who had been in our class the year before. So a rising second year medical student who needed a roommate. So she roomed with that person who was in our class, and when our class got back to Miami and had a party before classes started, she brought her roommate, who was Carol. So I met Carol 2 weeks before she started classes. We dated all through medical school, got married right after I graduated, and rest is history. That was almost 40 years ago now.
Was it kind of like right away you started talking to her and met her and like I have to go out with this person?
Oh, absolutely. Yeah, for
Yeah.
me, absolutely.
Yeah,
I
for
can't
you.
I can't
For
speak
you.
for her, but yeah, no, we it was a party, and I saw her walk in. I started talking to her, and just kind of chatted. We played some little drinking games kind of stuff, and the next morning I kind of woke up and said she seemed very cute, but I was quite drunk, potentially. So I called her and we played tennis. I played college tennis at Duke, and she played tennis in high school. So I called her and invited her to play some tennis, and we very non-threatening kind of thing. And that was our first date. And I took her windsurfing after that, and then the rest is history. Yeah.
Yeah, I have to get Gus here to insert a picture of your windsurfing. You kind of breezed over that. You didn't kind of windsurf. I mean, you were doing some competitive windsurfing, right?
Oh yeah, yeah. I was competitive. I did probably maybe 10 years competitive windsurfing. So I did some stuff on tour for a while, and mainly triangle and slalom racing and some and flat flat water tricks, but some wave stuff as well. Yeah, we went to
So
Hawaii.
you could you do the flip and the whole
Oh
thing?
yeah, oh yeah.
Yeah, that's
I did that on
unbelievable.
our honeymoon. Our honeymoon, we went to Hawaii. Yeah, I was at Hokipa Beach on Maui's North Shore for our honeymoon. Yeah.
So Carol met a successful cardiologist that ends up becoming a leader in the dive world and was a stud windsurfer and played for the Duke tennis team.
I yeah yeah I didn't do a whole lot with I wasn't a very good tennis player. I walked on and then played for a couple of years, but not I wasn't a star tennis player. But I played pretty well. I could play pretty well. But at the time, she actually we the joke always is that people say to me, "Well, you're so lucky, financially, you married an interventional radiologist." And I said, "No, I married a fourth year medical student with a 10-year military obligation." Okay, so and hers was similar. She met a guy who she liked who had a 10-year military obligation who was flat broke. So it took me 6 months to pay off her engagement ring. So yeah, we were pretty poor for a while.
It's great. I mean, you guys really went through a lot together and you're such a power couple, but it's just, I love that that's how you started, right? It's very real and
Oh yeah.
you've grown together. So let's get into some details. Would you say, can you share some pioneering procedures and then explain to me what you mean by you do heart procedures versus surgery that you've either developed or significantly contributed to in heart procedures? What's your favorite procedures? Why do you enjoy performing them? Tell us
Gotcha.
about that.
Okay, so yeah, you when you said things to me, you talked about surgery. So surgeries involves obviously opening people up with a scalpel. Okay. I do percutaneous procedures. So I do things through needle sticks. Okay. Now I work very closely with our cardiac surgeons for certain procedures. But they would be the first to tell you I am not a cardiac surgeon. Okay, those guys, that's a whole different level. It's a little bit different training thing, but the so I do a lot of non-surgical procedures, jokingly to try and put the cardiac surgeons out of business, by opening up vessels or fixing valves or replacing valves or closing holes or whatever, and do them with what we call percutaneous techniques, so through needle sticks and so forth, as opposed to actually having to open up the body. So it's a less invasive kind of approach. So that's kind of what I do for a living and what Carol does for a living as well, just from a radiology side. Um, as far as procedures, I haven't I haven't actually developed any brand new procedure. I'm not like Mike Young. I haven't invented things. Okay. What I am is basically an early adopter. So let's say that once something has been developed, um, my interest has always been to early adopt these things and help get experience for other people and help train other people in those types of things. So the first time that came about, um, coronary artery stenting, which is, putting balloons and then stents to open blood vessels up in the heart. The first stent that was approved to decrease renarrowing was what was called the Palmaz-Schatz stent in 1994. Julio Palmaz was Carol's boss when she did her interventional fellowship. And Richard Schatz was the chief of cardiology where I was in San Antonio in the Army. He was in the Army at the time when this was developed. So I was very fortunate to be one of the first proctors when this was approved by the FDA to fly around the country and help teach other doctors how to do this procedure safely because I've been doing them with the research side of things. So that actually is what led to my getting the job here, was through the network of that particular stent and the various reps. That's how I found the job here. And then I've continued that. Carotid artery stenting started in the early to mid 1990s, which is putting carotid stents in the carotid arteries rather than doing surgery. That was not an approved procedure, but some places were doing it around the country. I went to our hospital here and said, "Look, this is what some people are starting to do around the country. I think we should offer it to our patients. Um, I'll write up an IRB research protocol for it. You meaning the hospital, aren't going to get paid. Me." cardiologist, I'm not going to get paid either. So let's work out a way we can do this financially for our patients. So I started doing that. I wrote the first protocol in 95, 96. Um, and then we were involved in a lot of training with that. And again, I was a proctor for that. I flew around and taught a bunch of people how to do carotid artery stenting. Um, Same thing happened with some other procedures, mainly transcatheter aortic valve replacement, which was approved back in 2011, 2012. We started in early 2012, um, doing which is percutaneously through a needle stick in the groin, replacing someone's aortic heart valve. Okay. Which is a much less invasive procedure. You can imagine a needle stick in your groin versus opening up your chest. So we started that, a long time ago, and I've been fortunate enough to be asked. I work for the company. I'm one of the consultants and proctors for the Edwards Life Sciences, one of the heart valve, the leading heart valve company. So I've been blessed with the ability to fly around the country and teach people how to do that, and lecture and Zoom conference, all that kind of thing. And the same thing on another one called the Watchman, which is closing what's called the left atrial appendage, which is where a lot of strokes come from if people have atrial fibrillation. So if they have atrial fibrillation and are at risk for stroke, but yet can't take blood thinners for some reason, we can put a little, looks like kind of a cork in a bottle, in this left atrial appendage. So that was approved in like March of 18. We've been doing some research with another device before that, but it started in March of 15. We started in April of 2015. And again, I work for Boston Scientific. I fly around and teach people how to do that. And I've been fortunate to fly. I was in Porto Alegre, Brazil, back in July, presenting some data and teaching some people some things there. So I've been kind of blessed to do those sorts of things. Now, as far as when you say what's your favorite procedure, that is kind of like when somebody asks you what your favorite dive is, and you always say the next one, right?
Yes.
That's kind of how this is. It's kind of whatever's coming next, because when you started doing coronary stents, that was a big deal. I mean, it wasn't being done. Okay, now it's like a 10-minute procedure. It's like I've done thousands and thousands and thousands. So do I enjoy that? Yes, I'm helping somebody. Someone's having a heart attack, you interrupt the heart attack, you're helping them. That's wonderful. But it's bread and butter, right? Same thing with PFO closure. When PFO closure started, big deal operation. Now it's, 50. I did one yesterday in 15 minutes. Okay. The guy went home to Montana this morning. Um, so, that's pretty easy. TAVR, the transcatheter valves I was just talking about, when that first came out, huge deal. Okay. Hours and hours of time, one in a day, maybe two, it would take all day. Now it's an hour-long procedure. We do 4 or 5 in a day like it's nothing. Watchman, the cork in a bottle thing I was talking about just now for people with atrial fibrillation, again, used to be a big deal. Now we do 6 at a time. We'll do 6 in a day like it's nothing. So currently, the next thing for me, the next thing on the horizon is there's a percutaneous mitral valve that was just approved within the last few days, and I'm working on getting that into our hospital, and that'll be my next fun thing to do.
This opens up so many interesting questions. So the first thing I'm thinking about is that you have said the word teaching and training at least 5 times during this conversation. So first of all, how long have you been in this career? Just how long have you been doing this?
Okay, I graduated medical school in 1986.
Okay.
Almost 40 years.
40 years. You don't financially need to do this anymore. Would that be a fair statement?
Absolutely. Oh, yeah.
So
why do I do it?
Why are you still doing it? Because you're just nonstop.
I I enjoy it. I mean, as
Yeah.
you know, and you can tell probably from the discussion, I'm an educator at heart, right? I mean, that's my, I hopefully when I get to heaven, if I go to heaven, God will say, I made you an educator and you did a good job. That's my hope. So I enjoy teaching. I've always enjoyed teaching. That's kind of why I became an instructor, instructor trainer, so forth, is all that. And I enjoy teaching medical students and cath techs and all that kind of stuff. So that's kind of how all that happened. I just enjoy teaching. When it comes to the procedural things, you look at it a couple of different ways. The simplistic way is just to say, I still enjoy what I do. Okay. I don't want to do it 110 hours a week. And that'll lead into something you can talk about later, which is I've slowed way down. My wife, she retired in 2019. Um, I went to part-time about 2 to 3 years ago. So now my hours really aren't that bad. And I just do elective things, more the advanced stuff like we talked about. So I don't have to get up at 3 o'clock in the morning. I don't work nights, weekends, holidays anymore. So it's actually a very easy lifestyle from that standpoint. And I think I enjoy it. Now, the other way to look at it, which you and I are both religious people, I think God gave me a talent, which I'm very grateful for. I still think I'm pretty good at what I do. My hands are still pretty good. My mind is sharp. So I think I should keep doing things as long as I can, if I'm still helping people. Now, if I start to slip, and my partner say you need to stop, I'll stop. Okay. Or if for some reason the community, the business, the whatever becomes so annoying that I just isn't worth it anymore, that'd be one thing. But otherwise, I have no real plans to retire. As long as I can keep doing a few things and helping people and keep us on the cutting edge of technology, then I plan on working for years, I hope.
Well, that's what I was going to ask you. How much longer are you going to do it? You just answered that. But even if you stop the procedures at some point for whatever reason,
Uh,
uh, you could teach,
sure.
right? You could teach. You could continue teaching. What you mentioned PFOs. Can you a couple things? How many have you done? What are they? When do you decide to do the procedure to close them? Um, and just talk about that in general. What is a PFO? Uh,
Okay. I can do that.
how are you dealing with it in diving, and how many are you doing, and so forth and so on? A lot of people have no idea what we're talking
Right.
about when you say the
So
word PFO.
Right. So I'll start the way like as if you're a patient and we're kind of having that discussion, and then I'll kind of go over
Good.
indications for why we close it, and then kind of how I got into diving. Excuse me, like I mentioned before we start, I'm getting over the flu, so I got a cough. Sorry.
Bless
Anyway,
you.
if I tell people, Woody, if you think back to biology class in high school, okay, which was a couple years back for both of us, but a couple years back, your heart has four chambers. It has two on the top, two on the bottom. Um, the wall between the two bottom chambers is a solid wall. The wall between the two top chambers is not. I don't have a way to draw this for you, but you can imagine the wall between the two top chambers. Part of it grows up from the bottom, another part grows down from the top as your heart's forming in the womb and as a fetus. Okay, and they don't. These two that are growing towards each other don't actually meet. They overlap, which causes a little bit of a flap. You can probably see like a little bit of a flap. Okay, I joked that God did a pretty good job in designing our bodies. Okay, other than knees. Knees, I'm not so sure about. But other than knees, I think he did a pretty good job. And this flap is there on purpose because the whole purpose of the right side of our heart right now for you and I is to pump blood to the lungs to get oxygen. That oxygenated blood then comes back to the left side, it gets pumped to the body. Well, when you're a fetus, you're not using your lungs. They're collapsed, they're full of fluid. You're getting oxygenated blood from the placenta. Well, the blood from the placenta drops into the right side of the heart. Okay. Now imagine if this right side of the heart is trying to push blood against these fluid-filled, collapsed lungs, that's very difficult. So the pressure on the right side of the heart exceeds that on the left side of the heart, and that flap gets pushed open. Okay. By having it pushed open, it allows the oxygenated blood from the placenta to cross over to the left side and get pumped to the body. Okay. So that's there on purpose. We
It's like
all,
a mushroom valve and a
right.
rebreather, a
It's a
little bit.
one-way valve, right? It's a
Okay.
one-way valve. So that happens. That's designed on purpose when we're a fetus. When you're born and you open up your lungs, because you're now breathing air, okay, all of a sudden it becomes very easy for the right side of the heart to pump blood to the lungs. It's only got to go a couple of inches and it's all just airspace now. So the pressure on the right side of the heart will now drop compared to the left side, and that trap door gets slammed shut. Again, your mushroom valve kind of idea gets slammed shut. And in about 75% of people, okay, over the first year or so of life, that will seal and become a solid wall, which means in 25% of people, that doesn't seal. So it stays a flap. Okay. So the first thing to emphasize to divers and to patients is this is a normal variant. It's not a disease. Okay. I have blue eyes. Fewer than 10% of people have blue eyes. I would like to think that's a normal variant, not a disease. Okay. I'm left-handed. Again, fewer than 10% of people are left-handed. Again, I'd like to think that's a normal variant, not a disease. Okay, so 25% of the population has this. The vast majority never have a problem. Okay, the two groups of people that can potentially get into trouble, there's a group of people, what's called cryptogenic stroke, which means strokes in young people for no good reason. We have no, a young person comes in with a stroke, you look at the carotid, you look at the brain, look at everyone, you can't find anything. The thought is that because you could have microscopic clots in your legs that would normally get filtered by the lungs, those clots could cross over this flap and cause a stroke. Okay, so, and that's where the data actually is, the randomized data, and that's where the approval process is. So the FDA indication in the United States for PFO closure is for cryptogenic stroke. It's not for diving,
Mm,
which sometimes is problematic in getting these things approved. The
mm.
second group obviously is divers because, as we know, we all develop some bubbles on the right side of the heart, right side of the body that goes to the right side of the heart with diving. And some people can have these little bubbles cross over the PFO and then cause decompression sickness. So they act more like an air gas embolism. The issue about who to close is a little bit problematic. I just told you 25% of people have a PFO. So 25% of people get bent. You'd expect to have a PFO. Okay. Well, 25% of people who slice their tee shot have a PFO. I'm pretty confident the problem's with their golf game, not with the PFO causing the slicing of the tee shot, right? So with decompression sickness, you always have to decide, is it likely that the PFO is contributory to the decompression sickness? Or is it just an innocent bystander, right? So as best we can tell, having a PFO increases your likelihood of decompression sickness about fivefold, okay, which sounds bad.
Wow.
But if you, that's a relative risk. From an absolute risk standpoint, for recreational diving, the likelihood of decompression sickness is somewhere around 2 episodes per 10,000 dives. So a fivefold increase would be 10 per 10,000 or 1 in 1,000.
That's tiny.
Right. That's why we don't screen people for PFOs, why we don't just routinely close them. Okay.
I see.
So we close them if people have recurrent decompression sickness of the types associated with PFO, which I'll explain, despite diving conservatively. Because the problem is not the PFO, the problem is the nitrogen loading or the helium loading, right? So the inert gas loading. So anything you can do to decrease the likelihood, decrease the nitrogen loading will decrease your likelihood of having decompression sickness, whether or not you have a PFO. So we first tell people dive as conservatively as they can, and only if people either can't because they're dive professionals, or despite diving conservatively, they continue to have recurrent decompression sickness. That's when PFO closure is an option. Okay, I counsel everybody to 3 options. Option number 1 is you can quit diving. Okay, if you don't dive, you don't get bent. Right now, I tell people the vast majority of people that make that decision, I don't see. Right, they decide that on their own. Option number 2 is to dive more conservatively, dive shallower, dive fewer times per day, shorter time, blah, 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 long safety stops, diving nitrox on air profiles, all that sort of thing. I kept mentioning of DCS of the types associated with PFO. Joint pain is not associated with the PFO. The PFO is associated with things that are mainly neurologic. So they would be cerebral symptoms, so stroke-like symptoms or brain fog, those sorts of things. Spinal stuff, so that would be paralysis, urinary retention. Inner ear, which would be vertigo and nausea, and then skin bends. There's a classic rash of skin bends. So that's kind of how we decide. Now, as far as how I got into it from a Dan standpoint was, as you know, I've been a technical diver and a cave diver for quite a while. And back in the early 2000s, I started getting lots of questions as this became popular in diving about what to do about things. And there wasn't a lot of data. So I literally sat down at a DEMA show at a bar with Petar DeNoble, who at the time was the director of research for Dan. This is also about the time I started being a consultant for them, unpaid. But we sat down at a bar and said, if we were going to design a study to decide what to do with PFOs and diving, how would we do it? Right? Because I keep getting asked questions. I need data, right? I'm a scientist at background, right? I mean, we need data. So ideally, you would have what's called a double-blind randomized controlled trial, okay? Which would be the patient doesn't know what they're getting, the doctor doesn't know what they get, It's a flip of a coin. That sort of thing. You follow them for many, many years. Blah, blah. We obviously don't have the funding for that. Your Dan dues aren't going to pay for that, right? I mean, there's no way we're getting that paid for. So we had to do an observational study where I contacted a bunch of people through social media and so forth. And we ended up with, I think, 77 people or something like that around the world who had made a decision on their own after getting bent and having a PFO if they were going to dive more conservatively or if they were going to get a PFO closure. And then we followed these people for 5 years. And we found that PFO closure, as best we could tell, decreased the likelihood of recurrent decompression sickness back down to that normal kind of 2 per 10,000, and that the diving conservatively worked, definitely decreased the likelihood going forward, but wasn't as effective as closing the PFO. Um, and the PFO closure was safe with very little in the way of complications. So we published that in the Diving Hyperbaric Medicine Journal with Simon Mitchell back in 2019. So that's kind of how that story got going. And then somehow I've kind of I did through no reason of my own, I've kind of become this PFO doctor for the diving community. I don't know how that happens. I mean, I've had people come from all the guy I just did yesterday flew down from Montana. And I remember telling him on the phone, like, there's got to be 200 cardiologists between, Bozeman, Montana and Lakeland, Florida that could close your PFO. I mean, you do not need to come to Florida to have this done, but a lot of people, because I'm a diver, they want to have it done by somebody who's a diver, so they put it
Exactly.
down. So our cath lab is very, very aware of that when young people come in, they go, "Let me guess, you're a diver," kind of thing. So it's kind of an inside joke now in the cath lab.
Well, with that said, I would imagine some people have this same question on everything you just said. Why would we not automatically, if somebody is getting bent and has a PFO as a diver, what's the downside of just automatically closing it? Why would we not? If it's
Okay.
based on
The
that data that you just said, right? 5 times less chance of getting
right.
bent.
It's all risk benefit, right? Again, the likelihood in general of having, let's say, decompression sickness as a recreational diver with a PFO is about 1 in 1,000. Okay, okay. So I would like to think I'm pretty good at closing PFOs, but I'll bet you my complication rate's higher than 1 in 1,000. So it's all a risk benefit thing. The risks are very,
Hmm.
very, very low. Okay. And I've been very fortunate. I've never had a serious complication with the PFO closure. However, things can happen. So if it was no risk and all benefit, certainly
Yes.
you just close them.
Okay.
But when there is at least some risk, we need to counsel people to that and give people options. So, I mean, I think it really kind of depends a lot on what type of diving people do and how much diving they do. Okay. If someone dives once a year on vacation and gets bent a couple of times, they may just say, I'll just go play golf, right? Or if somebody, let's say, is a recreational diver that enjoys just warm water, pretty fish, 40 to 60 feet, and they did a couple of 130-foot dives for something and they got bent a couple of times, and I tell them, hey, you're on air, you're at 130 feet. If what you enjoy is diving 40 to 60 feet, dive nitrox, leave your, and dive it on air profile so you get out of the water faster. Stay shallow. You don't really care about doing liveaboards 5 dives a day. Just do 1 or 2 dives a day. Do some long safety stops, and that should be fine. Then that's a very reasonable approach for that person and saves them any kind of risk of a procedure. Now, if you're let's say you're a deep wreck explorer and this is your job and your profession is diving, and let's say, or you're an instructor and that's how you make your living. And I say, well, you need to dive shallower than 100 feet and nitrox on air profile. And they're like, I can't do that, right? I can't do that. So I have to either change professions or I have to get my PFO closed, right? That person, I think it's very reasonable. They can make a risk benefit decision that for them as an individual, the very small risk, but the risk of having the procedure performed is outweighed by the benefits of doing what they enjoy and continue to make a living doing what they enjoy. So it all comes down to it. It's not a rubber stamp. I have a long and detailed discussion with every single patient about their individual options and their individual risks and benefits so they make the best decision for them.
Okay. Then one more question about this.
Okay.
what are the risks? What could happen? What are the complications
Okay.
in closing? You said you've had 1 in 1,000 or less, maybe none. I think you said. So what are the risks?
Okay.
What would you tell me if I was coming in?
Right. Theoretically, okay, now we're doing a needle stick into the veins in your leg, so there could be bleeding. Okay. Um, it's unlikely that would be enough to, it's a vein, it's not an artery, so the likelihood of bleeding enough to cause a transfusion or some is unheard of, possible, not likely. Um, you could have a bruise. That's not a big deal. Okay. You could have a reaction to the anesthesia. We don't put people under general anesthesia. We would give them kind of conscious sedation like you'd having a colonoscopy or something. But you could have a reaction to anesthesia. That'd be very unlikely, but possible. Um, the device itself, we have to, place it across that wall where that flap is. Theoretically, some of these structures are very thin-walled vessel or thin-walled chambers, so you could have a complication with perforation of something and bleeding. Again, that shouldn't happen, but anything can happen. The device itself could theoretically embolize and come loose. Okay. We spend a lot of time and effort making sure it's exactly where we want it to be, and there's lots of ways to get around that. That should never happen either, but that's what we look at that. Um, there is the potential risk of, if, depending on if the device is oversized or put in the wrong location, it can erode over months or years and cause bleeding that way. Again, I've never had that happen either, but it's a theoretical concern. Um, and then there's also, again, a theoretical risk if you needed some other heart procedures in the future and you've got this metal disc there, would you be able to work around that disc to do other future procedures? And that's not, I've done procedures around the device, it's not that big of a deal. So again, not likely to have any of these things. I think statistically, if you look at large randomized trials in that cryptogenic population, you'd have issues around 1% or something, probably something like that. There is some people will get some palpitations after the procedure because you got this thing in the heart. Um, there have, depending on the literature out there, is a little bit of a hodgepodge because in the United States we only have two devices we can use. In Europe there's a gazillion of them, and some of the trials that came out of Europe with a whole bunch of different types and designs of devices showed an increase in atrial fibrillation for a period of time, usually within a month or so after the procedure, irregular heart rhythm, which went away in 45 to 60 days. We've not shown that in the device that I use, so I'm not really particularly worried about that with patients. I've never had that be an issue. But again, so there are some things you have to always think about. They're not common, but you personally, Woody wouldn't get a 1 in 1,000 chance of something. You'd either get a yes or a no, right? So that's why we have those discussions with everybody to make sure they're making the right decision for them. So it's a long visit in the office.
Yeah, but I think this is going to help a lot of people understand
Yeah.
what those potential risks are. Have you ever had somebody who was a diver and was getting bent and needed a PFO where you told them, no, I don't think you should close it?
Absolutely, all the time.
You have. Okay.
I've had more people. I have more people that I've told they should just dive conservatively, or that the PFO isn't related to the symptoms they had, than PFO closures. So I mean, no, yeah, the most of the people I see, I try to steer them towards diving conservatively, and then use the PFO closure in a very select group of people. And I've asked you next, I've done hundreds of them. I don't know if the number is hundreds of PFO closures.
Well, based on this, is it safe to say that, I mean, would you call yourself pretty knowledgeable with decompression, illness, and sickness in
I
general compared to the general population? Would you say
Compared
I'm
to the general
knowledgeable?
population, yeah.
Okay.
I am qualified in hyperbaric medicine. I do not practice hyperbaric medicine. I've done the 40-hour course, so I'm aware of it and I know how to run a chamber. I've never actually done, I don't do hyperbarics, but I'm aware of obviously diving medicine and aware of hyperbaric medicine.
Okay. And you are aware that, at least we think, that I was once bent. Would you
Yep.
say that you think I was bent?
Yeah.
If you had to guess, you think I got bent?
I told, I kept telling you guys called me. I kept telling Gus, take you to a chamber, take you to a chamber, take you to a
Yeah.
chamber.
And when I got bent, let's say I got bent. Let's take that as a fact. We discussed with you my dive computer, my dive profile, uh, been diving for a long time.
Hmm?
Would you say I was a diver that was in pretty decent health and shape at the
Absolutely.
time? And
Sure.
when I
You're
dove,
climbing the Dolomites and going skiing.
and I'm getting to a point here. When we went through that with you, and Dan asked me the same questions, not only did I follow the dive computer, I always do a piece of advice you gave me. Why not take an extra minute at that 20-foot stop? One more minute
Or a few minutes for that matter.
or a few minutes, which
Whatever.
I did. I did that as well.
Hmm?
And you said I would say, I'm going to say for you, you're very knowledgeable in this area. Why did I get bent?
Bad luck. We don't understand it. This is not
Amazing.
physics. This is not physics. This is physiology. Okay. If you have a physics question, there's an answer. It's math, right? You throw the human body into it, it becomes physiology. And everyone's physiology is different. Okay. So why did you get bent? You got bent probably because of the profile. It's a 3 hour dive, right? This wasn't 15 minutes in a 20-foot lake. This is a 3 hour cave dive. Okay. So the number one reason you got bent was the profile, right? That's the number one risk is the profile. Okay. That's what people don't understand. Um, and I tell people,
But on another day, I could have done that same 3 hour dive,
no
which I've
problem.
done.
Yeah.
Come up, go to lunch, had a great day. Nothing was different. Zero
Nope.
was different in my actual diving.
And you've been
It's
diving for
amazing.
40 years.
And
Yep.
we just
We don't
say,
know.
I just can't. It's amazing. We just don't know.
We don't, the problem is Neil Pollack has a really interesting slide. It's got like decompression sickness in the middle and then like 50,000 things with arrows feeding into decompression sickness. So like all these variables. So trying to control, I mean, hydration. Okay. Yeah. Hydration is important. PFO. Yeah. PFO can be important, but all these things are contributory, but the main thing is going to be the dive profile, right? How deep, how long, all that kind of stuff. Gradient factors help, but gradient factor or those sorts of conservatism helps for sure. But again, you're looking at a mathematical model, okay, the Buhlmann model, mathematical model, to try to predict your individual physiology. The other thing, the reason you got bent is you're not 25 anymore, okay? As we all know, certain parts of our body don't work as well as they used to as we get older. Our body is not as good at handling decompression stress when we're 60 like it was when we were 20.
And that's a fact. That's
That's
not
a fact.
guessing.
Yeah,
That's their
yeah,
state on that. Yeah.
yeah. You people bubble more when you get older. I mean, it's just the way it is. So the problem, though, and this led me to something that made me think of something. And I'll take me, you're an instructor as well. So we, as a dive industry, unfortunately, have vilified decompression sickness.
Exactly where I was going to go.
Yeah,
This is where I was going to go. Take
yeah,
it.
we have vilified decompression.
Yes.
So what happens is we think, oh crap, Bill got bent. He must be a bad diver. Don't dive with Bill,
Yes.
right? The way to think of decompression sickness is it's a sports injury. Okay. If LeBron James turns his ankle playing basketball tonight, are you going to go, what a horrible basketball player? He sprained his ankle. No, you play enough basketball, you sprain your ankle. Okay. Decompression sickness is a sports injury. If you dive enough, you're going to get bent. Okay. That's just the way it is. Now, you can do things to try and keep that from happening, just like you can wear proper shoes and tape yourself and decrease your likelihood of getting a sprained ankle playing a lot of basketball. You can dive conservatively and you can pad decompression stops and you can stay hydrated. You can check for a PFO and all these things to try and decrease your risk, but you can still get bent. Okay. It still can happen, just like you can still sprain your ankle. Okay. Same sort of thing. So that's on us as an industry. And because what happens then is people will say they get denial because they'll be like,
Exactly.
well, I did everything right. I didn't do anything wrong. I followed my computer. I've done this dive 100 times. I can't be bent.
Yes.
Yeah, you can. Yeah, you can.
And when you're bent, you
You deny it.
literally it's not even a conscious denial. It's like I'm I'm not aware that I'm bent. And the reason why is because this magic word bent, it doesn't really have this really definitive symptoms. I've talked to you about this since my episode. It's not like, Oh, yeah, you're bent because you can't move your arm anymore. Oh, you're bent because you're itchy, or you're bent because you can't breathe. You're just, maybe you're bent because you're just exhausted and tired. You don't really know you're bent. You
Right.
just
The
are
issue,
not feeling well.
right. The issue is just like everything else in medicine. Okay. Like for me in medicine, people don't come in and say, I'm having a heart attack. How do I feel? Okay. That's easy. You can look that up in a book, right? They come in with a symptom and you have to decide what is that symptom from? Okay. It's the same thing with diving. People show up with a symptom that could be from lots of things. Okay. The numbness and tingling they're having could be a stroke or it could be decompression sickness. Okay. The breathing problem could be air gas embolism, could be decompression sickness, could be pneumonia, could be a heart attack with pulmonary edema. Okay, lots of things. So it's a I in medicine, it's the same way with diving. In medicine, you have to take a symptom and then say, okay, putting the whole symptom and the whole history together, what list of things could this be? And then write them down, okay, from worst to least important, and then cross things off the list. So in your particular case, I mean, you had some non-specific symptoms, but you just done a 3-hour cave dive. So your symptoms are
It was
decompression.
awesome, by the way. It was
I know.
awesome. I
Your
want to do it
symptoms are
again.
decompression sick. I know, I've done that dive. Your symptoms are decompression sickness until proven otherwise, right? So sometimes going into a chamber is therapeutic. Sometimes going to a chamber is diagnostic. No, meaning that you go into a chamber, they take you down to 60 feet, and you go, wow, the symptoms all went away. Guess what? We just made a diagnosis. We treated you and made the diagnosis. Other times they may say, you did a 6-hour treatment. You know that funny symptom you're having? It didn't change. Guess what? Probably wasn't decompression sickness in the first place. But we have to err on the side of being cautious and checking.
Yeah. If if to advise divers and instructors out there, what do you recommend they do for somebody that they may suspect is bent, absolutely in denial? They're like, I'm not bent. Let's go. I'm fine now. I breathe some oxygen. What do you tell the person taking care of the other person to do with
Call
somebody that
Dan.
is like me?
Call
Yeah.
Dan. That's why
Yes.
we're here. Put
And
them
what
on
would
oxygen.
Dan?
100% oxygen is not going to hurt anybody. Put everybody on oxygen. If you have any question, 100% oxygen, call Dan, and they will direct you to get to the closest hospital. Okay, not the closest recompression chamber. Get the closest hospital because you need to be evaluated first. Like I said, not everything that happens diving is decompression sickness. They will then help coordinate getting you to the closest recompression chamber. That takes divers. That's the other concept. What people don't realize is not all recompression chambers take divers because most recompression chambers are set up for wound care, okay, which is Monday through Friday, 9 to 5. They're not set up for staffing on nights, weekends, holidays because you have to pay people to be on call. And if you're going to take care of 1 or 2 divers a year, you have to pay people to be on call 24/7, 365 days a year. They're not going to do that. So you may show up at a chamber that isn't open, or they may say, we're full. We've got elective patients all day. We can't take a diver right now. So that's why you want to coordinate everything through Dan. Get to the call, put them on oxygen, call Dan, get to the closest hospital to be evaluated, and then Dan will help coordinate getting you to the proper chamber if needed.
And do you think we should keep Dan informed as things are progressing through our
Absolutely.
case? Like we go to one place, but now we have to go to another place and so forth.
Yeah,
Yeah.
your
Yeah.
situation, as you know, was a weird,
Yeah. And
perfect story. But anyway,
I want to get into it. We're going to
I
get
think
into
it's
it a
kind of cool.
little bit because yeah.
Anybody that gets the opportunity should go to Dan headquarters if they can, and look at how the medical staff takes care of all these people. There may be 45 people on this massive screen, okay, on board. It has their name, be identified, but the incident, where they are, when they were first contacted, when they were last contacted, when are they going to be contacted the next time. And what they do is currently at Dan, there are 3 different call centers in different time zones so that it's always 8 to 5 somewhere. So between here or South Africa or New Zealand or whatever, we have so that they'll turn over every 8 hours. North Carolina may turn things over to someone in the Pacific where it's now at 9 to 5 for them. So that's always daylight. So someone's always checking on you during daylight, hours for them to keep people in the loop. So that's all been changing in the last couple of years and Matthias has Nishino, who's done a phenomenal job of that at Dan. He's in charge of that, so that maintain the communication. So they will contact. You don't need necessarily contact them. You should, but they will be in contact with you to kind of follow up on things.
Just for the record, I happen to be a huge, even more so fan of Dan and super proud of them for a number of reasons that are going to lead into my next question. Based on my situation, it's no secret. Many people have watched the video, and by the way, we were not perfect. I'm going to say that again because I want to say that right now. We did some things wrong in my situation. We did some things wrong. The people I was with, we could have done some things better, but it's easy to point fingers when you're in that moment. Okay, I'll just tell everybody that. But based on that, many people still put comments in and ask, well, should I get Dan, and what did Dan do since my episode? Have there been any changes? Because you're now the chairman of the board of Dan. Maybe as a result of my situation, maybe it was already in progress. But what is Dan's? How did they grow from this?
Gotcha. Let me first explain the organizational structure of Dan, because, my opinion, we've the impression in the diving industry is that Dan is an insurance company, which is not true. Okay. Dan was founded in 1980 for diving safety, education, and research. So if you join Dan, $45 a year, as a Dan member, has nothing to do with insurance, member, then you get the benefits. You're supporting the mission of education, science, research. You get either the digital or the paper version of the Earth Diver magazine, and you get travel assistance, so that if you were to have any kind of a problem, they will get you home. Okay. And that's, remember, you need to be a diver for that. I mean, if you were to be out hiking and have a problem, break a leg, Dan, if you're a Dan member, will get you home if you're more than like 35 miles from home or something. So that's a reason to be a member in and of itself. Then, back in the day, Dan members were starting to get bent, or were getting bent, and a lot of your private insurance won't cover treatment for decompression sickness. So Dan said, our members need help. Our members need some way of having coverage for decompression sickness. So Dan partnered, that's important, partnered with insurance companies. Okay. So the insurance company actually provides the payment and all that kind of thing for for recompression treatment. Dan coordinates things and takes a small premium, a small, whatever, a monetary amount, some small percentage to connect the member to that insurance company. Okay. So the insurance company is actually who's taking care of that. That's where you got into the mess, because that insurance company was requiring a whole bunch of paperwork, which became a nightmare in the situation. Now, there's lots of things going on behind the scenes, which we won't talk about with the Bahamas and whatever. But anyway, that being said, so that has changed. So Bill Ziefel just retired, and Cliff Richardson's now the CEO. But Bill was very big on saying that should never happen. So that has been taken care of. That has all been streamlined. So people will not have to do all this paperwork just to get treated. Okay.
Definitely huge, big
Right.
change.
Also, Dan members should not be charged like you had to come with a credit card. The reason you contact Dan is Dan has an agreement with various physicians and various recompression chambers around the world. Okay. So they have a contract with them that says, we will pay you, and this is what we will pay you for our services if our member gets sick. And they have that signed. So they'll say, Woody, you had a problem. You need to go to this person and this hospital. We have a contract with them. You won't get charged a nickel because we have a contract with them. The problem you got into, and there's some other places around the world, okay, not everybody is above board, okay, is, well, my cousin does this, or my friend can send you here, and yada, yada, yada. So you end up at some place that Dan does not have a contract with. And in fact, the place you went to, Dan has been trying to have a contract with them, or at least this is what I was told. But they wouldn't sign it because they wanted to charge whatever they wanted to charge. And Dan said, no, here's what we pay. And they're like, we're not going to do that. So if you end up at that institution, Dan can't help you because they don't have a contract with that person. They can't make them take their credit card. That makes sense? So that's the other way
Yes.
to keep Dan in the loop because Dan all around the world has relationships with recompression chambers all over the world, and contracts with those people, so that you should not be in the situation where you were, where you had to have a credit card. So that was the reason that was you were in the wrong place, because someone had told you, well, don't go here, go here, and you were just sick and doing the best you could, saying, sure, if you get me there faster, let's go there. But the problem is that was somebody who was not associated with Dan, getting you to somebody who they knew that was associated with Dan, and all of a sudden now you've got to pay out of pocket because they say we're not going to take care of you, and all that can be avoided if we stay in the Dan network where they purposely set this up all over the world. So again, you were in a situation of a perfect storm. That is not the usual experience with decompression sickness in dealing with Dan.
And Dan recently, relatively recently, without mentioning any names, had another, I believe, situation where somebody was bent in the Bahamas. They probably, Dan, I would think, may have remembered my particular situation. What did they do with that person? This was a recent story that you
Well, it
told me
wasn't. I
about.
don't think it was the
What?
decompression. It was the shark bite.
Oh, the shark bite. Excuse me, the shark bite.
Yeah,
What
within
did they
like
do? It's
within a few.
unbelievable.
Yeah, they called the people called from the boat to Dan. Dan scrambled a plane, and they had them in the hospital and treated within 6 hours in Miami from the Bahamas.
Unbelievable.
Yeah, so
Unbelievable.
that's the way it should work. And that was the plan with you. The plan with you was to get you to fly a plane into Nassau and get you back to the States. The problem was then the whole thing of, well, we won't, my buddy or whoever it is, this plane, we'll let them land, but won't let a plane land from the United States. It's after dark. A
Exactly.
whole bunch of stuff behind the
They
scenes.
squeezed me, is what happened.
Yeah, that's what I'm saying. Not
They
Dan,
did. No, no, not
the
Dan.
local
They
people.
did. And
Dan was
Dan
trying
was
to help.
stuck. They were stuck. And they couldn't help me really.
Right,
It
they
was a
couldn't.
tricky situation. But what would Dan do now? I want to go diving in the Bahamas. Many
They've got a
people.
chamber now. There's
There
a
you go.
chamber.
Okay.
There's a chamber in Abaco. There
So
you go.
there you go.
So the key is, and again, some certain things, if you, hindsight's 2020, right? Monday morning quarterbacking. Okay. If you guys had recognized your symptoms as being decompression sickness earlier, so it wasn't dark, and had contacted Dan, and Gus's voicemail wasn't full because they couldn't leave a message. They couldn't get
Yep.
they couldn't get so then things probably would have been entirely different. But things happen for a reason. So things did change at Dan for some of the things from the insurance side that Dan, not Dan itself, but the insurance company Dan partners with. They've changed some of that. And they've now, Brian has helped them get a recompression chamber in Abaco. So things have kind of worked out. So
Yeah, I really admire Dan for that. They did make change. They definitely reimbursed me for everything, and I'm just really appreciative. I would not ever not carry Dan. Let me just say that to
every
everybody.
diver should be a
It's
member.
crazy. It's crazy not to, honestly.
Right.
So, Doug, in 2025, can you tell us how many dives have you done? And then of those dives, how many were just enjoyable? I'm going underwater with my camera and enjoying myself versus teaching.
And in 2025,
Yes.
well, I don't do as
Uh,
much fun diving as I would like. Okay, we'll say that. So, because I end up teaching a lot. I don't advertise. I'm not. I mean, I just people call me and I, try to set things up. But so I think when I looked, I think I sent you this text a few days ago. So it was kind of a joke. I think I did 254 dives this year. I think that's what I told you, something like that. And I think of those, 40 or 50 were fun dives. Most of them were travel with my wife. We had the dive talk meetup. That was fun. I had a trip a couple weeks later with Dan to Grenada, so those were fun dives. And then Carol and I went to Wakatobi, so those were fun dives. And then I did a couple of days of fun DPV cave diving with Medi. And I think other than that, I had a student with me on every single dive. The remaining 200 dives for the year were all with students.
Incredible. I mean, so what would you
And
say?
I do
How
have
are you
another
bal
job. right? I do have
That's
another
what I was going to ask. Like,
job.
how are you balancing? Like, if you had to say in general in a month, what percentage of your week, there's only so many hours in the day, is diving, whether recreational or teaching, versus being a very well
Cardiologist.
respected cardiologist?
Okay. Well, I don't work very hard anymore. Okay. I used to put in your typical 100-hour weeks kind of thing, as a cardiologist. But and back then I was probably doing maybe 100 dives a year. That's all I had time for. Um, Currently my schedule is very easy. I only see clinic a few days a month. And what I see in clinic is usually people pre-procedure for counseling, variety of procedures. 1 month follow-up, make sure they're doing okay. Then I turn them back over to their referring doc. Or I see diving medicine issues. I see, people that have had heart disease and wonder if they can return to diving, or they've had this or that, or they're a commercial diver, they need a dive physical or whatever. So I do that a couple days a week and then, or a couple days a month, and then whatever procedures that generates, I do. So it'll vary. I usually have, if I'm in town, maybe a couple of days of half days of procedures, maybe the equivalent of one full day, or maybe a little bit more than one full day of procedures per week. So not bad. And I move it around. I'm blessed to have a wife who's very understanding, and I'm blessed to have an office nurse who understands my crazy schedule, and we just have a calendar and we move stuff around. So, um, as an example, let's see, this week so tomorrow I start a cavern and intro class, which goes through Monday. And then Tuesday I have clinic. And then Wednesday I have procedures. And then Thursday I do a go upgrade class to Deco Diver, Thursday and Friday. And then the following Saturday I have 7 days in a row of a CCR cave and a normoxic trimix. And then I come back for another office day, 3 more days of procedures. And so it's just a rolling kind of thing.
How many uh, dive agencies do you teach for?
Um, I am an inactive instructor for SSI at the moment, but I'm active for NAUI, for SDI, TDI, for IANTD, for RAID, and for Dive Talk Academy.
And are you an instructor trainer for any of these?
I'm an instructor trainer for INTD. I'm an instructor trainer for Dive Talk Academy, and I'm an instructor trainer but only for the KISS units for TDI.
And how many different rebreathers are you certified on? Just
Uh,
certified. Doesn't have
yeah,
to be
just
an instructor.
okay. 13 or 14. Let's see. What is it? 1,
13
2,
or 14.
4,
It's
5,
good.
6, 7, 8, 9, 10, 11, 12. 13, and I'm also qualified on oxygen rebreather with the military, but you don't get a certificate in the military. So
Okay,
oxygen rebreather with the
14.
military, and then yeah, 13 or 14.
Okay, 14 rebreathers that you're certified on, that you've dove on and have experience. How many rebreathers are you an instructor on?
All but two of those. So I'm
That
not
you
I'm not an
loved.
instructor on the Revo, and I'm not an instructor on the Titan, but the other stuff
Got
I'm
it. Okay, then if you became an instructor on 11 of the 13,
okay. Hmm.
you loved them, you liked them, or you would
Oh
not
yeah.
have become an instructor on them. But now I'm going to put you on the spot, which happens sometimes in my interviews. Which rebreather or rebreathers, I'll give you the option to say two or three if you don't want to narrow it down to one, is your favorite, and why? What are you looking for Doug Ebersole to say, I love diving this rebreather, and here is why?
Okay. Um, Again, it's a little bit like saying, where's your favorite place to go diving? It kind of depends what you want to see, right? If you want to see sharks, go to the Bahamas. You want to see, whatever, beautiful stuff, go to Indonesia. So it a little bit depends there. So I started, let me give you a little bit of the let me give you my history first, because it'll make a little bit more sense. So I started diving semi-closed rebreathers in 2002. So the Draeger semi-closed rebreather, and then one called an Azimuth, which is an Italian one that has two different gases. You can switch gases. Those are basically just gas extenders. So they're quiet, warm, moist gas. They're quiet. It's more of a kind of like a gateway drug into rebreathers in my mind. So that's what got me originally, and I started teaching those. I moved to closed circuit rebreathers in 2003, starting with the Sport Kiss, which isn't made anymore, um, because it was lightweight and did the kind of things I wanted to do. And then a lot of my stuff has been through KISS since then. So the KISS Sport, I'm instructor on. The KISS Classic, I'm an instructor on. When Mike Young, because I know you, for the people who are watching, listen to Mike's conversation just a week or so ago, when Mike developed the gym, the semi-closed gym, I wrote the class for that for INTD. I'm an instructor trainer on that. And then when Mike came out with the Spirit, I wrote the class for that. When he came out with the Sidewinder, I wrote the class for that. Uh, there's another, actually a funny one that's called the Kiss Core, which you might not even know about. Um, Mike reached out to me one time and said he had three guys in South Florida who designed high-end aquariums for very wealthy people and then cleaned these aquariums. And there are some people who had these tall cylindrical things through several floors of their place. They lived in Miami. They wouldn't tell me the names of people, doesn't matter. And the problem with bubbles would destroy the jellyfish. So they wanted an oxygen rebreather to clean the walls. So Mike said, I'm going to make them the equivalent of kind of a Spirit with a 20-foot tether to an O2 cylinder so they can't go deeper than 20 feet. Can you teach them? And I'll teach them how to use it. I'm like, yeah, sure. So I called Craig Jenny who's one of the legal people for the dive industry. And he's like, absolutely not. You can't just teach people this thing. Your liability is sky high. So I had to get one of the units from Mike. He kind of pieced the thing together. I then had to write a course with standards, make a slide set, make an exam, submit it to IANTD, have it approved by IANTD so I could issue certification cards. So currently the core, the KORE, the KISS Oxygen Rebreather, has one instructor, that's me, and has three certified divers who have cards, and there's never been a course done since. So anyway, so we have that one.
And the Go. You wrote the course for the Go. A lot of people may
Right.
not know that you wrote it. You
Oh, that's
wrote
true. I
the
wrote the course
original
for the Go
course.
for
Remember?
IATD
You
originally.
did.
Yeah. And then so then of course the Go, because it's kind of a KISS type unit. And then I am an instructor on the Choptima, and I'm an instructor on the chest mount, the FX CCR through IQ Sub. So as far as which ones, your question was which one's your favorite. So up until probably 5 years ago, I would have said the KISS Spirit. Okay,
Mm,
because
I
I
love
go
it
all
also.
the time. It was very versatile. I could do anything I wanted with it. It's great. My wife's certified on it. Both our kids are certified on it. As you know, Kim, our daughter, is certified on it because she was your instructor. Um, so that would have been the answer 4 or 5 years ago. Um, Currently, I would have to say, and again, this is all personal opinion. I love the Sidewinder for cave, especially side mount, smaller cave, okay, kind of
Me
stuff.
too.
So I love that. I think it's still a little bit of a pain in the neck to put on, but once you're in the water, it's great. So I think that's probably my favorite for that type of diving. Um, for recreational diving, just warm water, pretty fish to throw something on would have to be the Go. Um, because it weighs 10 pounds for travel. It clips onto anything. I mean, this year I did a little over 100 dives, or right around 100 dives, I think, on the Go. And a lot of those were the dives in the Dive Talk meetup, followed by, I took it to Grenada and we dove the Bianca Sea at 150 feet. That's no big deal on the Go. And then I took it to Indonesia, dove for 2 weeks off a liveaboard in Indonesia. It's just easy.
Easy.
It's just easy and it works. Okay, yes, it's got 2.5, 3 hour runtime. Fine. Okay, I mean, I
That's
don't want to do a
plenty.
4 hour dive anyway. So there's that. The My other one that I have to put in that same group as being one of my favorites would be the Choptima. I do like the Choptima.
Yes.
I think it's a great unit. It also is chest mount, so it's got those advantages. The one advantage it has over the Go, in my opinion, is travel if you can't find sorb, because it takes an
Hmm.
extender cartridge. So I was speaking at a meeting for Dan a year and a half ago or so, and I was able to get oxygen easily because they have to have that for emergencies, but they had no way of really getting me sorb. So I threw in a couple of extended air cartridges into my luggage, into Carol's luggage. And
Nice.
it was easy. So then, so that's one advantage there. It's
I wish we
extremely,
had that, by the way.
I
That is
know.
such a great feature.
That's a nice thing for that. And then also I do like it, especially for deep stuff.
Yeah.
Um, I like the electronics for the deeper stuff. Um, it's just easy, and I oftentimes will have students with me, and if I'm at 250, 300 feet with students, it's just nice to have that, that electronic thing going on. I've done a lot of electronic reviews. Oh, and the JJ. I don't have the JJ on my list. I'm also a JJ instructor, so add one more to that.
Oh, okay.
It's just not on my list. So yeah, that's would be so my three go-tos at the moment would be the Go for almost everything, the Sidewinder for cave, especially side mount cave, and the Choptima for a little bit of everything. I do Choptima in the cave, Choptima deep, Choptima recreational, depending on the thing. So that kind of covers all aspects of things.
Yeah. I think people will value that opinion. That's why I asked you. And now I'm going to ask you sort of the final question.
Uh-oh.
In your opinion, where are we going? Like, what are the future innovations that are left? I mean, we could focus this on technical diving. I think that's mostly what you like to do. What's coming? You're sort of in the know. You're in conversations with Shearwater or the rebreather manufacturers. Where do you think we're going with all this? What's next? What could be
Right.
improved?
Well, obviously, from a rebreather standpoint, CO2 monitoring would be key. Um, there's issues with that. I use CO2 monitoring in the cath lab all the time. We have end-tidal CO2, so we know how people are breathing. So that's easy. But the problem with those things don't do well in warm, moist environments, which is obviously what rebreathers are. Um, and you need to know where to put the sensor because if you were to put the sensor, let's say on the left-hand side where your other sensors are, and you have a mushroom valve problem, you won't pick it up. You'll get hypercapnic from the CO2, but it won't be picked up by the sensor. So you can be falsely reassured by that sensor that everything's okay when it's not. So the best place to put a sensor would be right in the mouthpiece. Obviously, that's the worst place to put it for my wet and that kind of thing. So, but people work on that. So there'll be ways around that. So a CO2 sensor would be very, very helpful. Um, from a technology standpoint, anything that we could do for personalized decompression, that's a pie in the sky because, like I mentioned, there are
Hmm.
a huge, huge number of variables that go into decompression sickness. But if we had a way or could find a way to accurately measure someone's physiologic stress for the given dive they're doing on this given day. I determine the decompression risk for today versus yesterday or tomorrow, or you versus your buddy. That would be huge. So a lot of people are working on things for that, whether it be in terms of heart rate variability for decompression stress, some other things like that to look for early signs of stress. I think that's really key. But all this is kind of technology. The main thing I think we need to do is better training. Okay. We need to do better training. We need to not be pushing through people through pipelines, but spending lots of time pressing things like buddy checks, pre-dive checks, rebreather build checklists, and make that the culture. I train lots and lots of people, and as you know, I have a laminated checklist on every single rebreather, and I stressed every single person checklist, 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 checklist. I see people at the dive sites. A lot of them use checklists. A lot of them stopped. Okay, despite me harping on them all the time, the importance. Despite Jill Heinrich at Rebreather Forum 3 saying that no dead rebreather diver had been found to have a checklist in their gear bag. Um, so those sorts of things. And then from the general diving population, I think what we need somehow is to get back to not necessarily longer training courses, but more time in the water and more of a mentoring process. The current generation of people, and this is not right or wrong, it's just different. Is people live for experiences. They want to go skydiving. They want to go scuba diving. They want to go rock climbing. They don't want to make a lifetime commitment to skydiving or rock climbing or scuba diving. And the problem with that is they are probably not going to be as safe the times they're doing it or be falsely reassured when it's been 2 or 3 years since they've done it that they still know everything. So I think that's a concern. So we need to have some way of maintaining safety and maintaining. So really, what we need to develop um, is not certification, but qualification. Rather than have people collecting a bunch of C cards, look how good a diver I am. Being certified does not make you qualified, right? So we need to stress qualifications for the particular dive they want to do at this particular point in their life, as opposed to what their C card happens to say. And just that's more of a that's not a we can't legislate that. That's more of a culture. We need to the culture needs to change. Personal opinion.
Yeah, I agree. Well said. It's a lot of it ties back to ego. Like it's okay to acknowledge that I haven't done this in a while. I need to really go slow. I need to take my time. I need to get reacquainted. I need to really be sure I'm comfortable doing these things. A checklist is not something to be embarrassed about that you still use it because you have everything memorized. It's just there is a cultural in the tech community. I've talked about it enough to say that it seems to be some kind of an ego thing. But anyway, I said that was a final question, but really, if you this will be the final question. This really will be. If you're helping lead Dan, you're the chairman of the board, you're well-known instructor on many rebreathers we just talked about. Do you have sort of a legacy that you hope to establish? Maybe you just said some of it with the both the diving community and divers health and where are you pushing to lead Dan? Like, what's your final goal here? Legacy? What chairman of the board with Dan? What do you want to in a nutshell accomplish? As wow, Doug really helped
Such as
the
okay.
following.
First off, Cliff Richardson is the new CEO. Dan, he is in charge. Okay, we in the board are doing everything we can to support him. I just got tagged to be the chairman this particular year, which I'll do my best to help provide. Go with the mission and so forth. As I mentioned to you originally, I am an educator at heart. That's what I've always wanted to do. So I would like to think that I would be remembered. First off, I'm not planning on dying anytime soon, hopefully, and I'm
No,
not
no,
not planning on
I
stopping
don't.
dying. Not planning on stopping. I was just really bring it up. I was just given a lifetime achievement award by our hospital. I'm like, I'm still here. It's like, but anyway, but
It's just more of your mission. Like,
I
what
know,
do you what
I
what
know.
do you you're an influencer in
I'd
diving.
like to be remembered as somebody who drove safety forward. I'd like, I'd like to, and training, and I would like to hope that people thought I did a good job of training people to be qualified yet safe divers, and that I did something to drive the industry forward in terms of safety and so forth, and in terms of medicine, the same sort of thing. That I helped a lot of people. I think I've helped a lot of people. That I helped a lot of people in medicine. That I kept our community, our local community, on the cutting edge, so that they don't have to go to the Mayo Clinic. They don't have to go to wherever to get top-notch, state-of-the-art cardiology care. That they can get it close to home. So that would be my hope.
Well, we'll end the first interview of 2026 is with who I think is should have been first, which is you. And just on behalf of the dive community, thank you so much. You've influenced so many of us. Certainly me. I would never have even gotten into tech diving if it wasn't for you. And just thank you for being somebody that's approachable, that is a great mentor like you wanted to be, and that is always promoting dive safety. You are already have that legacy, and it's just really appreciated by so many. And with that, thank you so much. And
Thank
let's go
you.
diving.
Let's
I
go
need to
diving.
get in the water.
I keep
Yeah,
telling you that. You got to keep
I
telling you that.
know.
You got to
Soon.
stop working so hard.
I definitely agree.
All
Bye,
right. Take care.
everybody. Thank you.
Thanks.